quadriparesis without sensory involvement. Introduction. Spinal cord infarction is a rare but severe neurological event resulting from disrupted blood flow to the spinal cord akin to a stroke of the spine. Its occurrence is significantly less frequent than cerebral stroke, yet carries a high risk of lasting disability. A case report. A 77-year-old man with uncontrolled type 2 diabetes presented with acute right-sided hemiparesis of 4 hours duration without any facial deviation. Neurological examination showed intact higher mental function and intact cranial nerves. Motor strength of 4/5 in the left limbs and 2/5 on the right side, with an extensor response on the right side and flexor response on the left, and normal sensory system examination including cortical sensation. Initial non-contrast brain CT was unremarkable. And he was managed presumptively for ischemic stroke involving subcortical lacunar infarct, as patient had no facial involvement. Within 24 hours, his condition progressed to quadriparesis with preserved sensation, diminished deep tendon reflexes, bilateral extensor plantar responses, and bladder and bowel and bladder involvement in form of overflow incontinence. Brain MRI brain with spine was done. Brain MRI remained normal with prompt to MRI of the spine, which revealed a spinal cord infarction involving C3 to D2 accompanied by diffuse disc bulge compressing bilaterally transversing nerve roots. During recovery, the left-sided motor functions improved to 4/5, whereas the right-sided limbs showed limited improvement with upper limb 2/5 and lower limb 4/5. Patient was started on antiplatelets and statins. Discussion. Spinal cord infarction is a rare but critical cause of acute myelopathy, accounting for only 0.3 to 1% of all strokes. It often mimics cerebral ischemic events, particularly when presenting with hemiparesis. So maintaining a high index of suspicion is essential when initial brain imaging is unrevealing. The spinal cord's vascular architecture, especially the anterior spinal artery ASA, predisposes to its ischemia. The ASA supplies the anterior 2/3 of the cord and has limited collateral circulation. Accordingly, anterior spinal artery syndrome is the most frequently observed infarct pattern. Typical features include sudden motor weakness with loss of pain and temperature sensation, while dorsal column functions and cranial nerve integrity may be preserved, but in our case all sensations were preserved. MRI remains the gold standard for diagnosis, but may appear normal in up to 50% of the cases within the first 24 hours. Characteristic imaging findings later include T2 hyperintensity, the outside appearance on axial sections, and cord swellings, which are evident in our case. In our patient, the evolution from isolated hemiparesis to quadriparesis alongside normal brain imaging and eventual spinal MRI confirmation illustrates the diagnostic challenge. This case underscores the importance of early spinal MRI, particularly in patients with acute motor deficit and intact cranial imaging. In conclusion, spinal cord infarction, though rare, demands early recognition, especially when abrupt onset quadriparesis presents even without sensory involvement and initial brain imaging is normal. MRI remains the gold standard diagnostic tool for confirming spinal ischemia and guiding timely intervention. Prompt spinal imaging is crucial to avoid delay in diagnosis and improve patient outcomes. Thank you.